Good afternoon, my name is Gauthier. I'm a Belgian first-year urology resident, and today I'll talk about our experience in Ghent in robot-assisted kidney transplantation in children. I will also briefly discuss our way of troubleshooting in case of an arterial embolism. So end-stage renal disease is the 8th leading cause of death in India, and it has a huge cost worldwide. It is well known that the gold standard of care is kidney transplantation. In the recent years, there is a shift from open to robotic kidney transplantation in adults, and there is also growing evidence that kidney transplantation robotically has lower perioperative complications, improves patient comfort, and has equal graft functionality on the long term compared to the open technique. So, due to the anatomical and physiological differences in children, pediatric robotic surgery has several challenges. Such as a small abdominal cavity and instruments that are only designed for adults. So in our center, we performed in the last 7 years 10 robot-assisted kidney transplantations, all with living-related donor kidneys. We always use a low-pressure pneumoperitoneum of 8 mm mercury, and to match the size of the donor kidney, we either use the external vessels, like in the adult population, or the common vessels, the common iliac vessels. So the trocar positioning and the instruments we use are displayed. So we use a gel point spear umbilically, 2 robotic arms on the left side and 1 on the right side. So our technique is based on the Vaticuti Medanta technique. And a good, successful surgery needs first good preparation. So we start with robotic donor nephrectomy in the adjacent OR. Then we prepare the kidney on the back table and we wrap it in a gauze with slushed ice. Then we also prepare modified Toumi syringes with slushed ice. Then for the procedure, we start with skeletonizing the iliac vessels. And then we perform a retro-peritoneal pocket 2 centimeters above the cecum. We make a tunnel under the spermatic cords in case of a male recipient. And we put the graft intra-abdominally. And we start with the vein anastomosis. So we use Gore-Tex 6.0 sutures, continuous suture, first to the posterior wall, then we make a knot on 6 o'clock, and then we continue with the anterior wall. Then we go to the arterial anastomosis. So we put the bulldog clamps, and we make a small incision, small arteriotomy with the scissors first, and then we enlarge the hole with the aortic punch. And just like in the vein anastomosis, we also use Gore-Tex 6.0 sutures, continuous. So we start also with the posterior wall, and then make a knot on 6 o'clock and continue on the anterior wall. And then we flush with hypernized saline, and we tie the knots. Then we remove the bulldog clamps to allow reperfusion, and we remove the gauze. Then we fill the kidney retro-peritoneally, and we secure it with 2 or 3 hemolocks. And then finally, we tunnel the ureter under the spermatic cord, and we make a modified Liege-Gregoire ureter neocestomy. And in the sake of time, I will skip this part. So in our case series, we observed 2 intraoperative arterial embolisms. In this case, it was a pantaloon reconstruction of the arteries, and we saw that the upper pole of the kidney was poorly perfused. So we turn on ICG, and we see that one of the renal arteries is not well perfused. So we clamp the arteries proximally and distally with bulldog clamps, and also the second renal artery. Now you perform a new arteriotomy with the pot scissors. We introduce a Fogarty catheter, and we successfully retrieve the embolism. Then we close the arteriotomy with also Gore-Tex 6.0 single sutures this time. Then we control the vascularization, which was good afterwards. So we did a total of 10 kidney transplantations in children. The median surgical room time was about 4 hours, and the median consult time was around 2 hours. Each anastomosis takes about 50 minutes to perform. And as I told already, we have remarkably 2 intraoperative arterial embolisms, which we treated as I've shown. On the graphs, you can see the kidney function on the long term, both in creatinine or in estimated GFR. So we can conclude that pediatric robot-assisted kidney transplantation is both safe and feasible when performed by expert hands in a multidisciplinary team. It is a minimally invasive procedure that allows adequate kidney perfusion on the long term. Thank you.
What was your youngest patient? What was the youngest age and weight?
The youngest patient was 8 years old, and that's our limit.
What was the weight?
It was around 15 kg.
So I would like to know which is the smaller size that you will allow to perform a robotic kidney transplant.
In our center for pediatric robotic surgery, our limit is not based on age but on weight. So we use a weight limit of 10 kg. But in transplantation, Professor De Castaker only takes an age limit of 8 for transplantation and takes a little higher kg also. So he prefers to have around 15. And that's what the lowest was in our center.
Okay, with a kit in 30 kilos kit, you will not...
Excuse me?
A 30 kilos kit, you will not do a robotic?
Yes, we will do.
Ah, yes?
It's from 10 kg onwards.
Ah, okay.
Yeah.
Okay, thank you. And then in all cases, you will go to the common iliac artery?
Not in all cases. It depends on the vessel size of the donor kidney and the size of the vessels of the kit. So in younger kids, we have to use the common iliac vessels because we have to match the size of the donor kidney. And in older kids, we can use the external iliac vessels like in adults.
And did you get any trouble when you turn the kidney to the side for the size of the kidney?
No, most of the times we don't have trouble to flip it and to retro-peritonealize the kidney.
Okay,
No.
thank you. Thank you very much. Congratulations.
In any case, you did end-to-end anastomosis, or all cases was end to side?
All cases was end to sides.
So no case you required end-to-end?
No.
Like internal area?
No.
Thank you.
Good afternoon to everybody. Thank you. I'm here to present a single-port retro-peritoneoscopic renal withdrawal for auto-transplantation done at our institution, CittÃ della Salute e della Scienza of Turin, Italy. Chair Professor Paolo Gontero. Please, can you play the video? I have no conflict of interest. In our institution, the renal transplantation are performed by a multidisciplinary team, including vascular surgeon and urologist. So we present the case of a 56-year-old male patient with a 22 millimeters aneurysm of the distal third of the renal artery, as we can see in the 3D reconstruction. And the planned intervention was the single-port retro-peritoneoscopic renal withdrawal for renal auto-transplantation to solve the problem. We used a single port. Patient was put in a flank position, and the access was a petit triangle, and where we put the Alexis wound protector. Then we dock the single port, and the first step is the posterior lateral conal fascia and psoas muscle identification in the retroperitoneal space. And the first step is the gonadal vein identification, and it's progressive isolation. So we are in the left side, and this is a landmark to then understand other structures like the renal arteries we can see here in the pictures. And gonadal, then we complete the gonadal vein isolation, as we can see here, and the ureter identification isolation. It is very important to do a good isolation step. And this renal vein section. Here the isolation is very, very important because we have to preserve all the structures, and then a section of some lumbar collateral small arteries with hemolock. And then a progressive isolation of the renal vascular pedicle to isolate all the vascular structures. We use in this way hemolocks, yes, to clip the artery, and then we can see the single renal vein and the single renal artery, well defined. Then we move to progressive kidney defecting and isolation. This is very important, but later this procedure will done by a vascular surgeon. This led to complete kidney mobilization. and the completion of the ureter isolation until the bladder. So it is very important to maintain an adequate lasting long length of the ureter. This is very, very important in auto-transplantation. Completion of kidney defecting, mobilization of the kidney, and then the clip were positioned in the gonal vein, and then it was sected. Mobilization is now quite complete, and then identification of the adrenal vein originating from a posterior branch of the renal vein with this clipping and section. In the end, the kidney now is mobilized, and then we proceed to the completion of the distal ureter isolation. And then with the single port camera reverse mode that helps us to do better our job, and the clipping and section of the distal part of the ureter with a good length of it. Okay, now it's time to renal artery clipping and section with two hemologs, only two hemologs to spare the length. So this is very important. Renal vein clipping with two hemologs, not three hemologs, to spare also in this way the length. And then the patient has a left parectal lumbotomic incision to extract the kidney. This is the end of the +1, mobilizing the kidney, and then enlarging single ported docking and enlarging the access. Vascular surgeons are ready to prepare and to reconstruct the two main efferent arteries in ProLane 60, and to prepare the kidney for the open surgery classical renal transplantation in the left iliac fossa. So we do the transplantation by open way. Postoperative Doppler ultrasound shows no aneurysm remaining, and the operative time was 404 minutes. The renal function didn't decrease, and we didn't have a particular complication on that side. So single port is a feasibility and effective method of managing living donor kidney withdrawal in a full retro-peritoneal approach. Satisfaction was appreciated by the surgeon. Thank you for your attention.
Any question from the floor? No. Why you don't do the kidney transplantation using the robots also?
That's a good point. The fact is that, as I was saying, the transplantation in our institution is one of the biggest institutions in Italy. We do it with a vascular surgeon, and we are able to use Da Vinci platform, but vascular surgeons are very traditional, so they don't use it right now. They are learning, so I think in the future we will do it together and with them, so fully robotic.
Okay. And I saw that you use the hemologs in the. Do you perform living donation in your center or not?
We use mainly hemologs.
You don't change to the staples. You still use
we use like a metal small clip, the brown one.
in between.
Yeah, and but we prefer hemolog. Yeah.
Okay. And do you prefer the single port or robotic, a normal robotic nephrectomy?
Yeah, we prefer single port to access the retro-peritoneum. That was easy because this is the old intervention was retro-peritoneal, so that's the point. But we do a lot of living donor withdrawal for transplantation, not auto-transplantation, but we do it lab.
Okay.
Yeah.
Thank you very much.
Thank you.
Congratulations.
Good afternoon, everyone. It's a pleasure for me to be here, and thanks to the Vaticuti Foundation for selecting our study and for having me here today. So I'm going to present to you the ERAS-RACT experience on orthotopic kidney transplantation. As we know, kidney transplant is the gold standard treatment for patients with end-stage renal disease, as the 5-year overall survival of patients in dialysis is less than 50%. However, with the aging population, a higher proportion of patients with elderly or high comorbid patients are considered potential candidates for kidney transplant, but a number of them are not suitable for a standard kidney transplantation because of severe vascular disease or retained iliac fossa for previous kidney transplant. So in such cases, an orthotopic approach has been proposed as an alternative technique. As we know, the largest series published so far of orthotopic kidney transplantation was done by using the open approach, was published by Dr. Musquera and the Spanish group. They collected more than 200 cases over a 30 years period and then demonstrated the feasibility of this technique as well as the comparability in functional outcomes with the standard approach. But the complication rate was not negligible. It was as high as 23% of the cases. And as we know, in the last 15 years, the robotic approach has been implemented in kidney transplantation. And thanks also to the EROS-RAT group, several publications demonstrated the safety and feasibility of this technique, as well as its potential benefit in challenging scenarios. And this has led, at least in the groups that apply to the program, in an increased trend in the use of the robotic approach for kidney transplant that right now is mainly driven by the living donor setting. The robotic approach has been also used for orthotopic kidney transplantation. The first publication is from 2021 by the group of Professor Vigues, but beyond this first pioneering case, no other publication have been released on the topic. Since last year, we collected the data of 16 cases that have been performed in 3 different hospitals of the EROS-RAT group. 7 cases were performed using living donors, and about the surgical approach, all cases were performed using a transperitoneal approach with a 4-arm configuration, with a slightly different port configuration depending on surgeon preferences, especially for the gel point positioning. So in terms of surgical approach, first we performed the radical nephrectomy of the native kidney, and then we started with the orthotopic transplantation. So we put the graft through the gel point, and we started with the anastomosis. Of note, in the standard kidney transplantation, of course, you start with the venous anastomosis and then you go to the arterial one. In the orthotopic kidney transplantation, you usually perform the arterial anastomosis first and then the venous one because of the configuration of the native vessels. In terms of type of anastomosis, we prefer the end-to-end anastomosis for the arterial anastomosis. 75% of the cases were performed with the splenic artery, the rest with the native renal artery, while for the venous anastomosis we only use the native renal vein. And the technique is most likely the same as the one described already for the standard robot-assisted kidney transplantation, and we use a 6/0 Gore-Tex suture. While for the urothelial diversion, we use both urothelial anastomosis, like side-to-side anastomosis with a 4/0 monocrete suture, or reimplantation of the ureter, of the native ureter directly into the renal pelvis of the graft, and then the JJ stent was placed. Of note, in terms of results, we have 2 cases that were converted to the open approach. Actually, one was not a real conversion because it was just difficulty in placement of the JJ stent that was placed using the wound of the gel point that is about 4 to 5 centimeters, while another one was an early thrombosis of the arterial anastomosis that was then reperformed using the native renal artery. In terms of functional outcomes, 3 patients developed delayed graft function, while 3 patients had major complication. 2 were urinary leakage that were conservatively managed using the JJ stent, while another one was a thrombosis of the graft that led to the graft removal in the post-op period. But after a median follow-up of 9 months, all the other grafts were functioning with a median eGFR of about 50 milliliters. That of course is a little bit biased because 50% of our cohort was from the living donor setting, so it's like non-comparable to the previous one that you published. So in conclusion, this is the largest series published so far of robotic orthotopic kidney transplantation that is a safe and feasible technique for selected cases, of course, because patient selection is a fundamental criteria for this kind of technique, and of course in a high volume center with huge experience on robotic kidney transplantation. But the robotic approach may reduce the perioperatic complication rate, especially we had less vascular complication as compared to the open historical cohort, can reduce the hospital stay, and also may facilitate a better dissection of the vessels, of the native vessels. And of course this is just a pivotal study, so further studies are needed to confirm our preliminary results and to standardize the technique, but it shed a light on another possible application of the robotic approach in kidney transplant. Thank you so much.
Dr. Kumar?
Yeah, wonderful demonstration. And my question is, so I saw that in your picture you put the hand port in the same renal fossa.
Yeah, you're meaning gel point, yeah?
Gel point, yeah.
Yeah, we had, according to the hospital, because there were 3 hospitals involved, we had 2 different configurations.
Yeah.
So in the Fundación Buchwert where I worked, we put the gel point at the same level of the 3rd arm. Okay, so it was a pararectal incision, while in the Professor Bigues, that is Hospital Belvice, they prefer to put the gel point a little bit like in the fossa, iliac fossa, so at the same level of the forearm.
So one in either in iliac fossa or in the pararectal area. So one
Yeah,
port
it's the same positioning more or less of the of a robotic kidney radical nephrectomy. It's not. It's slightly. We usually put the trocars a little bit lower, as for a robotic radical nephrectomy, just in case we have to control the major vessels.
Yeah, sure. One of the indications, I think, which we are also contemplating in one of our patients, is when both the external iliac vessels are atherosclerosed, right?
Yeah, yeah.
And even the common iliac. So then you cannot put a heterotopic reimplant. So then the orthotopic transplantation is the best approach. If the celiac axis is normal, the splenic artery is good, and the rest of the lower vessels are atherosclerosed, then the only kind of option that you have is putting orthotopic transplant.
Yeah, definitely. Actually, all the cases need a pre-op like assessment that it has to be very careful, because the CTE angiogram is really mandatory for all the cases.
Yeah, definitely.
Because otherwise, you need to know pre-op which kind of vessel you're going to use. For example, because of course these are all patients that were going to be in dialysis, so all the native kidney are not functioning. So this led all the native arteries to be collapsed, so very narrowed. So most of the times you cannot use it, and of course also in the publication from
So
Dr.
as you said, you can use the splenic artery.
Yeah, in the 75% of our cases we use the splenic artery.
Thank you.
Thank you.
So one question. How do you know the direction of the flow in the splenic artery using the robotics? What you will do? No? Because sometimes the artery is so kinking, and then sometimes it's difficult to know the flow, the direction of the flow. How you
probe.
check that?
With the probe? With the intraoperative probe, like
Okay.
we use an intra-abdominal probe just to assess. Actually, all the cases where then we use the intraoperative probe to assess intraoperative Doppler. You know, 7 cases were done with living donors kidneys, so we need to be sure that that kidney was working. So we always use the intraoperative probe to assess the Doppler.
Okay, thank you. I just want to say one thing in the orthotopic, that sometimes you have, or you can use the artery, the native artery. So I always check if I have a good flow in the artery. I don't go for the splenic artery. So there are some cases that you can also use it, and it's much easier. So that's all.
Yeah.
Thank you very much, and
Thank you.
congratulations.
Thank you.
So the next one is the first intracorporeal extraperitoneal robotic kidney auto-transplantation. That it's from Belgium also. Dr. Pieter.
Okay, good afternoon. I'm presenting the world's first completely intracorporeal and extraperitoneal single port auto-transplantation. So, as Federico explained earlier, the kidney was taken out and put in the other fossa by the vascular surgeon. In our center, we put the kidney completely intracorporeal in the retroperitoneum in the left fossa on the same side. And I'm presenting on behalf of Professor de Kaastekker, who could not be here, and he's the main surgeon. So auto-transplantation, why do you do it? Very shortly, well, because of tons of reasons. Vascular abnormalities, as shown by Federico, but also for extended strictures, urethral lesions. We also did some cases in which complex tumors required very long clamping times, and so we had to do intra-arterial cooling, as well as some cases for loin pain, hematuria syndrome as well. Now, having the single port offers us the advantage to stay completely in the retroperitoneum, small spaces, no repositioning of the patient. Patient can stay supine, so in our case, patient was lying flat. I saw in your case, the patient was in the left flank position, and then lower morbidity because yeah, they have less scarring, less postoperative pain, and they go home quicker. So in this case, it's an 18-year-old female who had bilateral Raynaud's disease, and so she received an alcoholization of the lumbar plexus, which was not so successful because she developed a huge urinoma after that with failed stent removal. And after that, the diagnostic ureteronoscopy showed a very long stricture of about 5 centimeters, so more than 5 centimeters. And left remaining kidney function of 38%, so still worth to go for keeping the kidney intact. So there are therapeutic options for this young patient were lifelong stenting, or ileal ureter, auto-transplantation, or nephrectomy. And she decided to go for a single port auto-transplantation. So long story short, what do? We place a small incision with the big trocar on the left lower abdomen, parallel to the iliac crest. And we first have a nephrectomy phase where we first prepare the vessels, then we take we remove the kidney, and intracorporeal, we implant the kidney. So we start here, we go to the kidney, and then we go back. So here you see the procedure at hand. So we go in, we do the pelvic preparation. So we dissect the iliac and the iliac vessels, artery, vein, as well as the ureter. And when we follow this ureter, so we take the vessel loops, of course, as some for vessel manipulation. And here you see that very fibrotic ureter appearing. So this is really the stenotic part highlighted in yellow over there, which is very diseased. And so we follow it upwards, so the boom just rotates with us towards the kidney itself. And then the kidney is completely freed. Fatty tissue is completely removed, the arteries, veins, as well as the pilum. We sacrifice the gonadal vein. And in this case, this lady had 2 renal arteries. So then the question was, okay, can we sacrifice one of these 2 arteries, or should we do a dual anastomosis, which would make it even more complex? So kidney is completely free. There's some fatty tissue left here and there for easy manipulation of the kidney. And then we also did the sympathectomy. So here you see the lumbar sympathectomy. After alcoholization, we also completely removed the lumbar plexus. Double G stent was removed. The ureter was very patent at the higher level, and we clamped then one of these both arteries, and we see that the lower pole is actually not perfused. But after manipulating the kidney a bit, you see that there is some remaining perfusion. So the first plan was to keep that kidney only with 1 artery. We placed an extra air seal trocar to be able to clip so that the bedside assistant can clip very easily. And then you see here the clipping as preparation for the intracorporeal cooling. So we do small venotomy and as well as arteriotomy, and then we flush the kidney with saline at 4 degrees to make sure that until the effluent of the vein, as you see here, is transparent and clear, so it means that there should be no remaining clots inside. Then we we do an extra 5/0 proline suture type of good night stitch, and we take the kidney and we port it towards the pelvis. So here you see that maneuver happening. So we are able, completely retroperitoneal, to manipulate that kidney, where then the anterior part of the kidney is put towards the posterior part of the peritoneum, and then the transplant phase can start. So clamping the vein, doing the venous anastomosis, and then after that going for the arterial side as well. So here we finish with the second suture, the same technique as for Gauthier, so it's the same surgeon as well, so you see that it makes a lot of sense. Flushing then again to avoid these clots, and then doing the arterial anastomosis with the Gore-Tex 6/0. So two-sided anterior and posterior wall anastomosis, with after that again flushing before final closure of the arterial anastomosis. So both of them side-to-end anastomosis. So we finish the anastomosis, and we do the ICG, and then with the ICG, so you see that the turgor, the flexibility of the kidney is very normal for in this case, and we see that the kidney is being perfused very well by the single artery, as well as the urethral stump was also very nicely perfused. And then we use a Quill 40 suture to finalize the urethral anastomosis on the native ureter, so we don't have to do a bladder anastomosis. Voila, that's it. This is the postoperative view. So a small scar. Consult time 8 hours, so this is very lengthy surgery. Parameters were very normal, very little blood loss. But in the end, the postoperative plan was uneventful, apart from pyelonephritis on day 8. But discharge was on day 3 after removal of the bladder catheter on the same day. Normal flow on ultrasound, good kidney function. 4th week we removed the double J stent, again normal ultrasound, good creatinine, good kidney function, and also complete resolution of the remaining renal disease. Then at 3 months, again very good completion of the kidney function with no alterations. Very small scar, as you can see on the top, and the MSA scan, which is actually unaltered, so we did not really alter the renal function by surgery. So in conclusion, the single port extraperitoneal approach is feasible. It's an intracorporeal technique where you don't have to enter the abdomen. A small incision, which especially for these young patients is something which we had required plenty of times, where we were solicited for single port itself in the hospital. Well, hopefully more to follow like this. Thank you very much.
Dr. Kumar.
Yeah, wonderful technique. My question is, how do you explain that inferior polar vessel later on that part get perfused, because renal arteries are end arteries.
Exactly.
So that, and initially you show that lower part was not perfused.
Yeah.
But either that part will not perfuse later on, or will remain hypoperfused. Little bit periphery may come from the surrounding vessels, but that part. And second apprehension is that lower polar vessels usually supply to the some part of the ureter also.
True.
So there is and since you had a port here, so we could have taken out the kidney from the port, repaired, put the renal artery into the smaller one into the main renal artery, put the kidney back into the same port, and then you could have done the same thing without doing it, and that lower port would have been nicely perfused. So I just want to know why you have not tried to do the lower port anastomosis.
So what we saw from the lower pole, actually we do a lot of research on predicting perfusion zones and trying to know which part of the kidney would be perfused for what, using a ton of algorithms and validation. So we're very aware of the end renal vasculature not being anastomotic amongst the different parts. So my guess would actually be that this, the flow that comes in later is just venous backflow that we're seeing. So I think there's a very little chance that this is really as good as perfused as we see there. So I think it's partly venous backflow or some collaterals on top of the kidney. We did see that the part is very small, and we did this in other transplants as well, so, sacrificing some of these smaller branches. Why we didn't take it out? Well, it's very simple, because you have a 3 or 4 centimeter incision, so it would be it would be kind of difficult to fully take it out without completing the incision a lot bigger and taking it out. So it was a matter of doing the technique completely intracorporeal and getting the aesthetics and the scarring as little as possible. Now,
I'm a little confused about what was the indication for doing auto-transplant. Was it the lower ureter, which was a strictured segment? That was the indication?
yes.
So if the lower ureter is only strictured, didn't you try the body flap? Because body flap sometimes even can go up to the pelvic ureteric junction.
Yeah.
So if the upper ureter is normal, then why try this kind of a procedure before trying the other simpler procedure?
I see.
Secondly, how did Raynaud's phenomenon resolve after this procedure?
Yep.
Raynaud's phenomenon is a yeah, please go ahead.
So for the Renal phenomenon, it was very short in the procedure, but you actually saw the lumbar plexus, and we removed it surgically. So you can do an alcoholization, but well, at least in Belgium, we used to do these thoracic procedures in which you go transthoracic and then just cut the lumbar plexus, the plexus of the orthosympathetic vessels. So we saw the plexus, the orthosympathetic plexus, and we cut it. So this is really no longer alcoholization, it's really surgical removal. So that's why we think it was completely resolved, or quite confident that it was resolved on that side. Then the other question, why we...
Ureter,
yeah, long story short, your question is why do we make it so difficult? Right?
Yeah, that's right. That's
So we have a very big experience in auto-transplantation.
Okay.
And for us it was actually more of a way to show can it be done, and it is like the third or the fourth case that we try to go completely with a single port in these vascular procedures, so to speak, because of patient preference, that they really come to us and say, look, I don't want to have a scar here, a scar there, I think it's really important, I'd rather have my kidney out than having like 2 scars for these young patients. So that's why we...
A scar would not be a problem. I think it can be done robotically, right? The whole body flap can be just made and anastomosed to the ureter. Yeah.
Peter, nice work. Congratulations. I had a couple of quick questions. So, you know, we described this in Cleveland Clinic when I was a resident. Dr. Kayuk and El Tamami, they're the lead authors. But we did it completely transperitoneal, and one of the reasons was with this retroperitoneal approach. If you have the patients completely supine, the peritoneum tends to fall, especially if you have a tiny peritoneotomy. And in these cases, sometimes, especially with urine leak, the peritoneum can be very friable.
Yeah.
So, and then the other part about your question, if you do it through a transperitoneal approach, we would actually dock the gel port inside, and you can actually take the kidney out, backbench it, and then put it back in while someone's preparing the iliac vessels for the auto-transplantation.
Thank you.
Thank you very much.
Yeah, you want me to comment on any of that?
My question was like about if you have a peritoneotomy, how does Professor manage it usually?
Well, that's, to be honest, that's our biggest nightmare. You lose all
You
our
can
space.
talk together after that, so thank you very much.